Hello, everybody, and welcome to another edition of the National Fellow Online Lecture Series. This series is put on by the Fellows Online Education Subcommittee, which is a joint effort between the AMSSM Education Committee and the Fellowship Committee. My name is Dr. James Robinson. I am a primary sports physician at Hospital for Special Surgery in New York City, and I'll be moderating tonight's lecture. Just a few housekeeping. So the goals of this program is to enhance your home program's educational content, and we hope to provide fellows with direct access to education with experienced AMSSM members and at times invited guests. And the main purpose of this lecture series is to help assist in CAQ exam preparation. So we always want your input. So topics, speaker suggestions, you can go to the AMSSM website through the education and look for the Fellows Online Lecture Series. And you can put in topic suggestions. You can also put in speakers suggestions. Try to be as specific as possible when you put these in. And then you can also follow this QR code if you would like to help. And just remember, the primary goal is to assist in CAQ preparation. So if you think there is content that you don't get enough of in your home program that might be on the CAQ that you'd like to hear lectures on, that's what we're looking for. Just a few rules. So please mute your microphones and turn off your cameras to help. You are able to submit questions through the chat, and we'll take questions at the end. So just submit them through the chat, and then we'll do a Q&A at the end. And then there's also be a link at the end to complete an evaluation. We do value your feedback, so please keep that in mind. So without further ado, tonight, we are very honored to have Dr. David Siebert, who's going to speak to us on sudden cardiac arrest. Dr. Siebert is the Director of Sports Medicine at the University of Washington, where he also serves as the Fellowship Director of the Primary Sports Fellowship there. He is a team physician for the Seattle Seahawks, and he completed his fellowship training at the University of Washington in 2017. His past research has focused on the epidemiology of sudden cardiac arrest, which makes him a great speaker for the topic tonight.
Thanks for that introduction. And thanks to all of you for being here. I know it's the end of the day, and in some cases it's pretty late in the day, depending on what time zone you're in. So I really do appreciate it. And it's pretty cool to see this lecture series take off as it has. Was started, I think, 5 years ago, if I remember when the pandemic started. And it's really fun to see this move forward. And it's also fun to see some of the names I recognize out there in the audience. So thanks again for attending us here, attending today. I've titled my talk "Sudden Cardiac Arrest in Athletes from Screening to Survival" because we're going to cover a pretty wide range of topics here that hopefully are pretty high yield for your studies. And just to outline exactly where we're going to go, we are going to start by understanding the modern epidemiology of sudden cardiac arrest, which I'll call SCA quite a bit during this lecture, in athletes. And then we're also going to talk about high-risk athlete subgroups. We'll look at some of the common etiologies of sudden cardiac arrest. We are going to compare the merits and pitfalls of the American Heart Association 14-point pre-participation screening tool to those of the resting electrocardiogram. And then we're going to review the identification and treatment of SCA. And if I could leave you with one thing tonight, it's to really know those distractors that you have to make sure don't delay or deter CPR from being initiated. And that will be that will be clear later on in the lecture. So just quick background here. SCA, as many of us know, it's a very visible event, and it has a very profound impact, obviously on the athlete, but also their family, team, community, and leagues, and even countries at large, depending on the coverage of the event. If it were to happen on like a televised broadcast, for example, it's generally accepted as the most common cause of death in exercising athletes. Precise epidemiological data remain unclear, though I would argue in the past few years or so, they're getting clearer than historically. And historically, estimates of the incidence of SCA have been have varied pretty widely. Most of the studies over the past 20 years ago to 10 years ago or so were retrospective in nature and used varying data collection methodologies, some of which were a little less rigorous than current research methods. And then we should talk about the sports physical and what it is and why we do it in the first place. And I've pulled this quote directly from the Inter-Association Consensus Statement on the Cardiovascular Care of College Student Athletes. And the reason I bring this out is there's pretty widespread agreement across different societies that the point of the PPE is to, quote, identify conditions that may put the student athlete at unreasonable risk of death or catastrophic injury, with the potential to modify and reduce risk through individualized management. So many of you, if you have not already, will do many PPEs, and there's an important part to this, and that's going to be the foundation of really the rest of this talk. I'm going to pull out this diagram back from 1992, and this is from a paper by Van Mechelen and colleagues where we're trying to kind of conceptualize the idea of disease prevention. And in this case, the disease would be sudden cardiac arrest. And the first two steps in this diagram are really the basis of how you try to prevent the disease. And first, if you look at the top left, we really need to understand, how common it is in the first place. How often does it happen, and how bad is it when it happens? And then once we understand that, we try to understand why it's happening. So what are the underlying diagnoses in the case of SCA that are precipitating that event? And the definitions of, just to go back to some epidemiological definitions, they really matter. So to start pretty broadly, incidence is defined as the number of new cases of an event, a disease, in this case, a sudden cardiac arrest per unit time. And that sounds simple at first, but when you really drill into it, how precisely you define the numerator, the number of new cases, and the denominator, the units of time, is really important. So to start with the numerator, you have to think, are you thinking about cardiac death only, or cases of sudden cardiac arrest that are survivals? What is an athlete? That sounds kind of like an odd question at first thought, but the definition of an athlete can really depend on the league you're looking at or even the person you're talking to. And are you looking at arrests that occur only during competition, or is it at all times, like at school or at home? How do you identify the cases? Are you using media reports? Are you looking at catastrophic insurance claims, or is it other data? And if you imagine an event that's fairly rare overall, slight tweaks in the definition of the incidence, of the numerator and the denominator can really affect the numbers that you get. When you zoom in on the denominator definition in this calculation, one unit that you're going to hear quite a bit is something called an athlete year. And what an athlete year is essentially one athlete who's competing over 1 year. But it's simple at first, but then again, how do you find the number of athletes in the population you're studying? In the NCAA, it's a pretty defined number. It's a pretty concrete number that we can access. High school athletes is harder to get an exact participation number. And then you also have to think about multi-sport athletes. Do you need to count them more than once? Do you need to count them only once? And what's the correct calculation there? And again, it really matters. When you make small changes, the numbers of a rare event can change quite a bit. So let's look back at some of the past incidence estimations, starting back all the way in 1998. So Marin and colleagues at that time looked at Minnesota high school athletes as the numerator. They looked at deaths only, so not sudden cardiac arrest with survival, just deaths. They looked over a 12-year period, and they looked at cases that occurred during school-sponsored competition based on insurance claims that were made after the event. For the denominator, they used athlete years, which many of the studies we're going to talk about here use. And the results they came up with was about 1 in 217,400 athlete years. And then that led to the proposal of an incidence rate of sudden cardiac death of 1 in 200,000. If you fast forward now to 2013, Roberts and colleagues looked at that same population, Minnesota high school athlete deaths occurring over a 20-year period, again during school-sponsored competition, and based on insurance claims. And the denominator was the same, athlete years. And in this 20-year period, the results were about 1 in 417,000. So that is the proposal that was given in this paper. A few years later, another group reanalyzed the same population and same time frame as that most recent study. But in this case, they changed the numerator. So they changed the numerator to both arrests and deaths. So arrests that were successfully resuscitated and deaths over that same 20-year time period, occurring at any time, not just during competition, and based on insurance claims and media reporting, so such as news articles that report the collapse of a young, otherwise healthy athlete that sometimes make their way into the media. Athlete years was the denominator again, and the results in this case were 1 in 150,000. So still rare, but definitely higher, and it was the same athlete population, generally speaking, that they were looking at. So there's been a lot of studies on this question, and here are some that I've put in this diagram. And you can see that the numbers are a bit all over the place. So if you look over on the right-hand column, you're going to see that depending on the population of athletes that you're looking at, or if you are counting sudden cardiac arrest, sudden cardiac death only, or arrests and deaths, the numbers can be anywhere from 1 in 43,000 to 1 in 917,000 at the other end. So again, those slight tweaks to the definitions really make a difference. So what have we learned as we kind of gone through this epidemiological data, and what have we found in more modern data with higher rigor methodologies? This study came out just last year. Patik and colleagues looked at 20 years of NCAA athletes' sudden cardiac deaths occurring at any time. But the big change here was they looked at 4 different methodologies to identify these cases. There were 2 systematic databases that were searched through, media reports, and a pretty sophisticated search process through the media was done, and insurance claims were analyzed. Again, the denominator was athlete years, but when you employ this methodology and these numerator and denominator definitions, you get results of 1 in 63,000 athlete years. But then when you get even further into the subgroups, you see even more concerning numbers. 1 in 43,000 male athletes, 26,000 Black athletes, and 1 in 8,000 Division I male basketball athletes. So again, those numbers get striking pretty quickly depending on the population. Another study from pretty recently, I think 2020, if I remember correctly, Peterson and colleagues did a prospective study. So starting in 2014, and then prospectively monitoring 4 cases that happened, both cases of arrests and deaths at any time. And the methodologies used in this studies were autopsies, death certificates, medical records, media reports, and databases that were searched. And again, the denominator was athlete years. For this particular study, the results in high school athletes were 1 in 66,000, with 1 in 44,000 male high school athletes, 1 in 50,000 NCAA athletes, 1 in 35,000 male NCAA athletes, 1 in 18,000 male African-American NCAA athletes. And then probably the most striking number that I've seen is 1 in 2,000 male African-American basketball Division I athletes. That's a pretty striking number, 1 in 2,000, over a prospective study over 4 years. And then finally, the last study was just presented at AMSSM, the annual meeting just a few months ago. This is Wainwright and colleagues presented an abstract of that same study now extended out over 9 years. And in this numerator, it was the same, but a much larger time frame. The denominator was athlete years. And in this case, the results were 1 in 45,000 for all athletes, 1 in 29,000 for male athletes, 1 in 17,000 for Black athletes, and 1 in 5,700 for men's basketball athletes. So again, very, very different than 1 in 200. I asked ChatGPT for a little help making this slide, which is pretty fun, I have to say, when you make PowerPoints. I wanted to kind of get a visual representation. So I asked ChatGPT to make a white background with 200,000 black dots, and that's what this screen is. This is the old historical estimate of 1 in 200,000. But then when you go forward and you get to about 1 in 60,000, which I would say is an appropriate modern estimate for sudden cardiac arrest or death, you get a visualization that looks like this. If you look at the Patik study with male Division I basketball athletes, we're at 1 in 8,000, which looks like this. And then the Peterson study for sudden cardiac arrest or death, in male Black Division I basketball athletes, it's a even more striking picture. I would certainly argue that this is a this is a figure that should make us really think hard about what exactly is going on here and why these athletes are at higher risk in certain subgroups. So again, I asked ChatGPT one more time, one more question, and what is the best incidence estimation? And I actually am pretty happy with the response I got. And the underlying part there is about 1 in 40 to 1 in 80,000 competitive athletes per year, with higher risk subgroups down at the bottom as low as 1 in 3,000 or to 1 in 5,000. So what's causing sudden cardiac arrest in our athletes? It's obviously important to know the numbers. If you think back to that first step in that scheme, that diagram that I showed you about disease prevention. But the next step is what's causing this. So the fatigue study from the 20-year NCAA athlete study, the results are shown here. And you can see there's a lot of different diagnoses that can potentially lead to sudden cardiac arrest. So on the bottom left in the blue, you have autopsy negative sudden unexplained death, which is essentially an autopsy that did not reveal a pathologic diagnosis, suggesting that it was an electrical abnormality or an arrhythmia that took place. In the top left, you have hypertrophic cardiomyopathy. In the top middle, you have coronary artery abnormalities, and then you have a smattering of other diagnoses that could potentially precipitate an arrest. This is a similar diagram from the Peterson, the prospective 4-year Peterson study. And you can see, again, there's many different diagnoses that can predispose to this. In this particular case, hypertrophic cardiomyopathy was identified as the most frequent, as opposed to autopsy negative sudden unexplained death in the previous study. But then again, you can see everything from coronary atherosclerosis to long QT syndrome and several others. I'm going to dive into a few of the important diagnoses. They're all important, of course, but some of the ones that are going to be high yield for you. I'll start with hypertrophic cardiomyopathy. Many of us know that this is defined as an abnormally thickened heart muscle wall, often due to genetic mutations in sarcomere proteins. In some cases, like in the lower right part of your screen, this can lead to outflow tract obstruction and then eventually potentially ventricular wall scarring. This may, unfortunately, and often does, first present as sudden cardiac arrest, which is unfortunate because there's not many warning signs leading up to it in many cases. And then a recent evolution in recent years is that sports participation may still be reasonable with this diagnosis following expert consultation and treatment, sudden cardiac arrest risk stratification, and shared decision making. Historically, if you were diagnosed with hypertrophic cardiomyopathy, it was generally recommended that you were restricted from competitive sports, but that landscape is changing in recent years with some of the data and research that's been done. Another diagnosis that I want to spend some time on is anomalous coronary arteries. So, at a high level, this basically means that your coronary artery anatomy is abnormal. There are many variations of what this can look like, but one particularly important one to know about is the left coronary artery arising from the right sinus of Valsalva. And this particular diagnosis can cause anginal chest pain due to altered blood flow to the myocardium, eventually ischemic changes, scarring, and arrhythmias. But unfortunately, like hypertrophic cardiomyopathy, it can also first present as sudden cardiac arrest. The treatment of an anomalous coronary artery is surgical correction and then follow-up monitoring. That usually involves exercise stress testing and to be sure that there's no signs of ischemia or arrhythmia after the anomaly is corrected. And then sports restriction or participation really depends on the very precise details of the anomaly you're talking about, down to where the anomaly starts from, where the artery goes to, how it traverses there, the size and shape, and some really specific anatomic details. I'll also touch on a number of other electrical disorders here. So on the left, you have Wolff-Parkinson-White, which is a relatively common ECG abnormality that we see. And this is the pre-excitation abnormality where there's an accessory pathway that leads to pre-excitation of the ventricles. This is often seen as the delta wave, which is that slurred upstroke in the QRS complex that you can see in the ECG snippet on the left there, as well as a short PR interval. In the middle, you have long QT syndrome, which is an abnormality of repolarization that can lead to sudden cardiac arrest in certain clinical circumstances. Commotio cordis is the diagnosis that we believe Damar Hamlin suffered on national television, and this involves blunt trauma to the anterior chest at the exactly wrong time to precipitate a cardiac arrest. And then finally, autopsy negative sudden unexplained death is a very important probable electrical diagnosis that you should be aware of as a high as a relatively high frequency causer of sudden cardiac arrest. So that's the epidemiology and the etiology, and ultimately we're trying to prevent this, obviously. So we need to talk about the screening strategies that we have in place, and specifically, how do we detect these conditions before they cause that sentinel event of cardiac arrest? I want to start by asking the question, why do we screen in the first place? And I'm going to pull out a couple quotes here from the American Heart Association here, and then one from the AMSSM. And it's really widely agreed that we should screen. And the central purpose of pre-participation screening, just going into this quote here, of trained competitive athletes is to identify or raise suspicion of those cardiovascular abnormalities and diseases that are potentially responsible for sudden unexpected death on the athletic field. And just a year later, the AMSSM put out a similar statement. I'll jump to the second sentence here. Early detection of athletes at risk for sudden cardiac arrest and death is an important objective of the PPE for athletes. So that's why we screen, and there's generally good consensus on why we're doing it as well. Let's go all the way back to probably some of your early medical school lectures, and a paper here from 1968 from the World Health Organization. And the question is, what makes a good screening test? And this is pulled from this paper. And a good screening test has a number of criteria. There's 10 here that they call out. 5 of them are about the condition you're looking for in the first place, and 5 of them are about the test you're using to look for those conditions. So I'll read through them quickly. On the left, the condition needs to be an important health problem. Acceptable treatments have to exist. There must be a latent or preclinical state that exists. There must be facilities for treatment, and there must be a chance of a poor outcome if you don't screen for it. On the right, we get into the test that you're using to test for this, to screen for this condition. Ideally, it has a high sensitivity or a low false negative rate, a high specificity or a low false positive rate. The test should be easy and reliable. The workup afterward and the risks and harms associated with a positive screen should be acceptable. And the experiences of those false positives and the misdiagnosed should also be acceptable. Currently, this is the most widely used screening tool for these conditions that we're talking about, which is, again, the 14-point American Heart Association screening tool. I won't go through all of these, but many of you have probably utilized this before and will continue to do so in the months and years to come. But it is a 14-point questionnaire that is a targeted history, a targeted family history, and a targeted physical exam to try to tease out some of these conditions that we're concerned about. I want to call out a couple red flags on the 14-point tool that should really make you pause and think for a moment if you get a positive response. So the first one is exertional chest pain. This is potentially concerning for structural heart disease. So exertional, reproducible, and anginal chest pain could raise your suspicion for hypertrophic cardiomyopathy with outflow obstruction or those anomalous coronary arteries that we talked about. Another red flag on the 14-point tool is exercise-related syncope, especially sudden collapse without any warning. And this should raise your concern for structural or primary electrical disease, like some of the ones that I have listed on this slide. So cardiomyopathies, Wolff-Parkinson-White, and several others. I also just want to really highlight, as I mentioned, just drawing your attention to the right side on this slide, sudden syncope without warning during or immediately following exercise is a highly concerning history point. And I really want to emphasize that you should be very careful attributing a collapse out of nowhere without warning to exhaustion or dehydration, because that is a different collapse, usually a more slow collapse with a prodrome of feeling totally exhausted, a little nauseous, maybe some tunnel vision. It's very different than the sudden collapse that happens out of nowhere. And if you do have an athlete that does report they had suddenly had syncope out of nowhere, you want to start with an ECG, and then you strongly are going to consider an echocardiogram, exercise ECG test, or potentially a cardiac MRI, depending on the exact circumstances of the situation. So the 14-point tool, as we're going to talk about here going forward, is a very good starting point, but it has some limitations, and I'm going to dive into those here. I'm going to cite a couple studies from 2014 to 2016, and a couple of these studies had shown, and I'm just going to read this straight for you because it is important to hear, I think, that each of 8 college athletes eventually diagnosed with a cardiovascular disorder were done so solely via electrocardiogram in an otherwise negative screen, including that 14-point history and physical exam. And in other words, and another point of these studies is that not a single athlete with a positive history or physical exam finding was eventually diagnosed with a cardiovascular disorder. So some of the numbers that come out of those calculations is a 37.2% false positive rate on the 14-point questionnaire, and a less than 3% false positive rate of the screening ECG. And I bring those numbers up because I want you to think about those in the context of those criteria that we talked about that makes a good screening test. So I think that asks the question then, is there a changing paradigm here? And I will pull out a couple more quotes that I'm going to read verbatim because I think they're important. In 2016, my colleague, Dr. Dresner, wrote that the premise of cardiovascular screening in athletes is that early detection of cardiac disorders associated with sudden cardiac death can reduce morbidity and mortality, which we all agree on. And without believing in the benefit of early detection, then screening by any strategy is called into question. But if you do believe in early detection, which we do, as opposed according to those quotes that I had previously in this lecture, screening by history and physical examination alone is inadequate. And then later that year, the AMSSM put out a similar position statement, and one of the quotes I'll pull from it is that the current pre-participation physical evaluation, while pragmatic and widely practiced, is limited in its ability to identify athletes with conditions at risk for sudden cardiac arrest or death. So let's revisit that model from the beginning here. So we've established number 1 and number 2, relatively speaking. That data is becoming more and more clear as the years go on. Now we're going to talk about the third box in this diagram, and that's the idea of introducing something to try to prevent the disease, which is SCA in this case in the first place. And that's where we're going to start talking about the resting screening electrocardiogram. So this really started to gain a lot of traction in 2010, and it continues to gain traction currently to this day, and actually into the future in about a month, which I'll talk about here in a little bit. But the overall goal starting around that time was that we want to develop a set of screening ECG criteria that we can use to distinguish physiologic changes in the athlete's heart from pathologic changes that suggest an underlying disorder. And as I mentioned, it started in 2010 with the European Society of Cardiology criteria. The Stanford criteria were developed in 2011. The Seattle criteria in 2013. These were then revised in 2015. And then the current state-of-the-art international criteria are the international criteria from 2017. And again, the goal is we want to capture all pathology. We want to screen for and capture all that pathology and try to avoid false positives and limit the poor experiences of the misdiagnosed, as I mentioned in that one screening criteria from previously. As we go through this from 2010 until now and then next month, we have to ask the question, does refining the criteria come with a cost? So in other words, with each iteration of these criteria, are we sacrificing sensitivity to increase specificity? And fortunately, there's been a lot of studies on this already done, and the answer seems to be no. So this diagram is fairly complicated, but what we're looking at here is 5 different studies from 2013 to 2016, comparing the false positive rates of the various iterations of ECG criteria to each other. And you can see that we're getting better. So with the European Society of Cardiology criteria in 2010, that's the big false positive rate in the gold diagram on the left of each of these studies. As we move forward and march through the different criteria, we are getting better at lowering that false positive rate. These are some quotes from these papers. There's no change in sensitivity, 100% sensitivity, and etc. So the criteria are getting better. When the international criteria came out in 2017, another study that is similar to those was done. And as you can see in this table here, the specificity of the criteria were increased from 87% to 96%, but the sensitivity remained the same. So it's very encouraging to see. So I alluded to this a couple times, but next month, so September 25th and 26th in Seattle, there's going to be the 2025 International Summit on ECG Interpretation in Athletes. And the hope is that out of this summit comes the next iteration of these criteria to make them better and better, capture all pathology, and avoid false positives. So there should be details about that in your AMSSM email, so do check it out if you're interested. So then let's get to the heart of this. Let's compare the PPE to the ECG and see which one is better, which one is better at picking up this pathology. These studies have been done starting in 2018. Williams and colleagues looked at a large-scale study of 3,600 high school athletes. All of these athletes were screened with blood pressure, an AHA 14-point screen, physical exam, and a resting ECG. An echocardiogram was then obtained if the athlete had an abnormal ECG by the international criteria, a clinically significant response on the AHA 14-point screen, or an abnormal physical exam finding. This chart shows the results of this study in terms of a positive response to the AHA 14-point screening tool. And you can see out of those 3,600 athletes, 300 reported chest pain, 200 syncope, 250 shortness of breath. And you can see the numbers are pretty high. So you can imagine that of 3,600 athletes, there's very little likelihood that 10% of them have a structurally significant heart disease causing chest pain. So you have to wonder about the accuracy of these numbers. And the results of the study were that the further results of the study were that 16 conditions that were associated with sudden cardiac death were identified in those 3,600 athletes. Just one of the 16 that was associated with sudden cardiac arrest was missed with the ECG, but 9 of 16 were missed with the standard American Heart Association 14-point screen. So to put that into more practical numbers, going back to your statistics here, in the third row, what you're seeing here is the positive predictive value of the AHA 14-point screen is 1 in 116. And in this study, the ECG was 1 in 6.8. So let's revisit then the screening test criteria from that World Health Organization paper that I mentioned. I will say that the next 2 slides are my opinion only. There is no science behind the boxes I'm going to put up here, but I would argue that if you look through those 10 criteria for the AHA 14-point questionnaire, the criteria that are green, I think, are met. The ones that are yellow, I think, have pluses and minuses to them. But then the sensitivity and specificity questions of the AHA 14-point questionnaire, I would put in red, so not very effective. If you then compare that to the resting electrocardiogram, while this science and research is still ongoing at a pretty rapid rate, I would say there's a little bit less red when I go through each of those 10 criteria and more green. And there's definitely subjectivity to this, and it depends on the situation that you're in and the expert consultation that you have available, the hospital workup and testing that you have available if needed. But this is what I would code each of those criteria. And unfortunately, despite whatever you use, AHA 14-point questionnaire, the ECG, or some other strategy, unfortunately, screening is not perfect. And we've seen some recent examples, even just over the past few years, on pretty widely televised events. So you have to be ready, and just to pivot here to the management here, you have to be ready to manage sudden cardiac arrest. It's, as we know, like an extremely time-sensitive situation where you need to be ready to go at pretty much any time. And this all starts with preparation. So the Emergency Action Plan, or EAP for short, is essential. and a comprehensive, detailed emergency action plan down to where the AED is and who has the key if it's locked and which door is going to open for the ambulance. A detailed emergency action plan is essential for the appropriate response to sudden cardiac arrest and should be considered a requirement for safe practice and competition. And the EAPs ideally should allow for successful defibrillation within 3 minutes or less. And the sooner is the better. The sooner the better. And it sounds silly, but honestly, the successful defibrillation of an athlete does imply the actual presence of an AED in the first place. So it is something that we should really emphasize in our communities, that having that AED available, charged, accessible is really important, because if you don't have one, or if you do have one, but it's behind a locked cabinet that nobody can get to, you might as well not have one. So it's really an essential component to this, and it should be a requirement for safe participation along with the EAP itself. Let's turn to recognizing cardiac arrest. So this will be probably the most important couple slides I leave you with here, because I want to emphasize in this point, if I can leave you with this is, if you take nothing else from this, please take this point. Any athlete who collapses on the field and you see them collapse or they're down on the field, when you're running out to them, you are assuming they are in cardiac arrest until you can prove otherwise. And it can get really tricky, and it is essential to avoid distraction from the following clinical signs that may delay starting CPR or even deter starting CPR altogether. And unfortunately, it does happen. So those signs are seizure-like activity, which have been shown to be present in over 50% of cases of cardiac arrest, agonal respirations or gasps, or abdominal movements that look like normal breathing. The eyes don't have to be closed. They can be open or they can be rolled back, and that can still be sudden cardiac arrest. And then finally, this one's a little tricky too. You want to be careful you're not falsely interpreting your pulse as the athlete's pulse. So if you're out on the field, it's a soccer field, a football field, whatever, and you have to run out there to the athlete that's down, your heart rate's going to get up and you're going to feel it pounding in your chest. You're revved to go. You're going to try to respond to that athlete, maybe a little nervous, anxious, whatever. Your heart's going to be going, and you have to be sure that you are not thinking you're feeling the athlete's pulse when it's actually your own. So again, one thing I'll leave you with, assume cardiac arrest until you can safely prove yourself definitively otherwise, because it's an extremely time-sensitive situation. I'm going to pivot to a video here, and this is from my colleague, Dr. John Dresner, who has this video published. I think it's a very great visual representation of what we can see when there's a cardiac arrest. I am fairly certain you'll be able to hear this, but Andy, please flag me down if you can't.
Hi everyone, I'm John Dresner, Director of the UW Medicine Center for Sports Cardiology, and in the next 100 seconds, I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did, in sports from football to lacrosse to baseball.
In Mark Vivian Foe, he shows all the signs of sudden cardiac arrest: continued breathing after collapse, eyes open and rolled back, the face of sudden cardiac arrest. For DeMar, after his arrest, his arms go up with seizure-like activity. And for Christian Erickson, a sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
We've been there, but that's not a good look at all.
With Claire, dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life.
Okay, I've seen that video quite a few times. It's pretty striking every time I watch it. But it really does show some examples of what you could potentially see that may not initially strike you as cardiac arrest, but again, you have to assume until you're safely proving yourself otherwise. So hopefully none of you are confronted with this situation, but if you are, as I mentioned, time is of the essence. You want to start CPR immediately, and that includes getting an AED, and you continue high quality CPR until the athlete is transferred and formally handed off to emergency medical services care. Chest compressions are at a rate of 100 to 120 per minute and 5 to 6 centimeters in depth. And then you want to defibrillate with an AED as soon as possible. And most cases of witnessed sudden cardiac arrest are in ventricular fibrillation, which would be a shockable rhythm. And can you survive SCA? And that's the ultimate question. That's why we really care about all of this. And the answer is yes. So with proper recognition, initiation of CPR and early defibrillation, and an execution of an EAP that involves EMS, sudden cardiac arrest is a survivable event, and this has been studied. So in 2019, this paper out of Sports Health found an overall survival rate of 48%. But then when you really drill down into some of the data and some of the cases that they looked at, if an ATC was present, that survival rate was 83%. That's a huge jump. And then if a defibrillation happened, or defibrillator was used, I should say, the survival rate jumped to 89%. So, sudden cardiac arrest, time sensitive, very scary events, but 90% survival rate when it was responded to appropriately. If you do respond to it appropriately, this is my second video. Hopefully some of you saw this. Just I think last year in 2023, it's pretty striking moments, and this was Damar Hamlin at the ESPYs.
Please welcome this year's recipient of the Pat Tillman Award for Service, the training staff of the Buffalo Bills.
Okay. And, really obviously very powerful moment, and kind of really why this all matters and why we do all this preparation, why we do the EAP and come up with such a detailed plan, why we go to those yearly rehearsals. This is why. And, I think for those of you that follow the NFL, he had an interception. I think if I remember correctly, his first career interception last year, a year after he suffered cardiac arrest. It's pretty incredible. Okay, so that's going to wrap up the bulk of this talk. We're going to go into some CME questions here, and these are challenging in some respects, but they're really designed to kind of hammer home some of the most important points. So Andy, if you want to bring on the poll part, I can start with this question. So for the first question, all of the following are clinical distractors that may inappropriately delay the recognition and management of SCA and worsen outcomes, except eyes are open, seizure-like activity, abdominal breathing, gasping, mistaking your pulse for the athletes, or F, all of the above. Excellent. Yeah, so good. That's good. That's the point. For those of you with test taking, know how tests work, all the above, always pay attention to that one. Okay, so that is the answer. And again, this is just driving home the point that if you see these things, it can distract you. But remember, you're going out there and you're assuming that that athlete's heart is stopped until you can prove yourself otherwise. All right, for my next question, a little bit tougher. Which of the following is not a higher risk athlete subgroup for sudden cardiac arrest. Female athletes, basketball players, NCAA athletes, all of them, meaning all NCAA athletes, male athletes, or football athletes. Perfect. Thank you for participating, everybody. And yes, pretty consistently throughout the literature, female athletes have been found to be at lower risk. Importantly, not no risk. Again, not to sound like a broken record, but if you have a female athlete go down and you're assuming that she's in cardiac arrest until you can prove otherwise. And then finally, probably toughest question. So despite the limitations of the 14-point PPE that we talked about, which of the following below symptoms is the most concerning and may require further testing? So these all may be concerning in their own way, but I want you to think about which one is the most concerning. So abdominal pain with exercise, a history of exhaustion on a hot day, followed by tunnel vision, slow collapse, and eventual syncope that self-resolves with leg elevation, sudden unexplained syncope without obvious causative factors, a history of a quadruple bypass in a grandfather at age 72, or sharp chest pain in the side of the chest wall that relieves with repositioning. So yes, the answer is C. And the difference here that I really want to highlight is the difference between B and C. So regardless of the kind, the way that a syncope happens, the circumstances behind it, you should really, really unpack that episode of syncope. But after you do, and you get the history and the resolution and that sort of thing, there is a pretty substantial difference between B, the slow, I'm hot, dehydrated, tired, I slowly collapse and I eventually kind of, get pre-syncopal or syncopal, but when you elevate my legs, I come to pretty quick. That's one kind of syncope. A sudden, out of nowhere, maybe it's a cool day, maybe they're not dehydrated, out of nowhere they're down, and then they get out of it, and either with defibrillation, of course, or just on their own. That's a very different kind of syncope that you should really, really pay attention to. All right, so just to wrap up for today, just a couple conclusions to leave you with. Sudden cardiac arrest and death is the most common cause of death in exercising athletes and is more frequent than historically appreciated, as we went through. The optimal cardiac pre-participation strategy remains unclear, and there's a lot of research and debate about this, but it has been, the AMSSM position statement has stated that the AHA 14-point pre-participation tool is limited in its effectiveness. The underlying causes of sudden cardiac arrest and death are a heterogeneous group of disorders with hypertrophic cardiomyopathy, coronary artery anomalies, and electrical disorders among the most common. And then finally, high quality CPR and an effectively executed, that should say EAP, can make SCA a survivable event, and beware those clinical distractors that we talked about. All right, right on. Well, thank you for your attention, everybody. I hope that this was helpful. I'm happy.
Great. Thank you so much. That was excellent review. So we have one question in the chat so far, but if you do have questions, please put in the chat. We've got about 9 minutes or so to go over questions. So the first question is it known why basketball players are such a high-risk population for sudden cardiac death as opposed to athletes in other sports?
The short answer is no. The longer answer is there's some thought about the how stop and start basketball is, potentially that plays a role, but we don't have any evidence to back up that conclusion that I'm aware of. There's also the thought that football and basketball may be overrepresented due to media bias. So it's a more widely attended and viewed sports that maybe it leads to more likely to be reported on by the media. But we don't know really the answer to that question is the short answer. That data, if I could add one thing about that data about basketball and football athletes being in a higher risk subgroup is pretty consistently shown in the data. So, despite the data collection methodologies, the populations, and the actual media capture rate of the cases, it is pretty consistently shown despite the methodology. So there's definitely something to it. I don't want to oversubscribe to increased media as being the reason. There's definitely something to it because it is pretty consistent.
Oh, that's an interesting question. So, do you think that
Mm-hmm.
there's any utility in a limb lead ECG instead of a 12 lead to help
Sure.
facilitate ease administration, especially during mass PPE events?
An interesting idea, but I have to say, I mean, with all the rigor and science that goes into interpreting these ECGs, I think it's I mean, is there utility? I think the answer is probably yes, but can you base that on, the kind of well-validated science that's coming out about ECG interpretation criteria? I don't think so. So I think we have to be really careful about kind of going outside the box, despite that it is an easier ECG, as you mentioned. Are portable echoes at mass screenings reliable? I mean, I think that like a lot of things, that depends on the quality of the ultrasonographer and the machine that you have, which of course are barriers depending on where you're practicing. I mean, at the University of Washington, we're very fortunate to have our echocardiogram techs come with us to our screening events and have a sports cardiologist interpretation on site. But obviously that's not everywhere in the country. So I think it's a valid point, and it just kind of depends on the resources you have. And then in terms for Noah's question about robust evidence to state that female athletes are not a high risk group, I mean, I think it's kind of my same answer for basketball and football. It is pretty consistently shown throughout pretty much all of the studies that I have ever looked at that do break it down by different demographics that female athletes are at lower risk.
And I think you made this point, but I definitely just, want to emphasize this with our fellows. No screening tool replaces being ready for a cardiac emergency. Because, we know that, like we've seen D1 basketball players have probably the highest risk of sudden cardiac arrest, and probably most of those are screened with ECG and probably echo at most D1 universities. So even the well-screened athlete can still have sudden cardiac arrest. So you've got to be prepared for it no matter what.
Totally. And that 90 or 89% or 90% survival rate is one of my favorite numbers in all of the research about this. Like if you're ready, you can help those athletes.
So the Jason asked about the slides. So the slides aren't available, but the presentation will be placed on the AMSSM YouTube channel. So you can go back and watch it as many times as you want. You can, fast forward through the parts that you need. So it will be posted to the AMSSM YouTube channel, usually tomorrow or in the next few days. Sorry, one more question. Is there any other current areas of research in this topic aside from the new criteria that may be coming out?
Yes, there certainly is. We have quite a few projects going on at University of Washington. So some of the more active studies are survival rates by survival rates of sudden cardiac arrest based on demographics, which is always an interesting study, and ongoing incidence work. So Dr. Wainwright's 9-year study is ongoing to my knowledge. And then the ECG criteria summit next month is a big one.
And then Andy did post on the cardiovascular screening participation position statement that's on NBJSM. And then also, I think, you had mentioned briefly, but especially for our fellows that are kind of the what you do with these athletes once they have screen positive has changed. I mean, in my 15 years, has changed quite a bit. Used to it was you're out of sport for the rest of your life. Like you can participate in pool and and like table tennis, I think was on the 1A.
I remember
kind of
that
things,
that diagram.
Those have definitely changed, and with the adventation of internal defibrillators that are more widely readily available, ablation techniques that are more available, there are athletes that are able to return to sport.
There certainly are, and a sports cardiologist consultation, which it really is nothing can really replace that, but is really helpful. And there are kind of risk stratification tools that we can use to even drill down to, once you have hypertrophic cardiomyopathy, are you at high risk of arrest, or is this what we call a genotype positive phenotype negative case? And in that particular case, where you do have the the genotype positive, but you don't actually have any manifestations of it, it's pretty widely accepted that you are able to participate even if you do have that gene mutation. So there's a whole spectrum of risk stratification there that can happen.
Great. Also in the chat, Andy posted that the BJSM interpretation, ECG interpretation, and athlete there, which is free event that you can do. And just for the fellows, this will absolutely be on your CAQ. So make sure you know the international criteria. It will absolutely be on your CAQ.
We didn't go through the ECG criteria themselves, but which is its own kind of lecture and workshop. But the online, did you say you linked to the E Academy?
Yeah, there's also an E Academy. I think.
Yeah.
I think he did the live. He linked the live event that's happening in September.
Oh,
as
great.
part of your-
Okay. Oh, yes, right. The event in September is to refine the criteria. It's a pretty cool event with a lot of international experts coming on. In terms of learning the actual criteria themselves, if you look up ECG criteria, E Academy, if you Google that, it's a free tool as well, and it was really the thing that made me extremely confident in interpreting these. There it is. Thanks for that link, Andy. If you go to that, that's really where I became very confident with the criteria. It's a very well designed design program, and I had nothing to do with developing it, so I'm not just saying that because I helped make it.
Well, great. Well, thank you very much. And stay tuned next week for our next lecture. And everybody have a great night.
Great. Take care, everyone. Thank you.